This is a patient who presented with massive saddle pulmonary embolism on EKOS therapy. He is a 75-year-old white male who came to the ER complaining of chest pain and shortness of breath that had started 3 days prior to the presentation to the ER. The pain was in the center of his chest and it hurt him when he was breathing and with minimal activity. He stated the pain was 10 out of 10. He tried to rest, but the pain stayed constant and he was also very short of breath. He said that he is not compliant with his medications at home and that he takes what he needs when he feels like it. He has a past medical history of high blood pressure, coronary artery disease with 4-vessel bypass. That was in 2000. Cardiomyopathy, congestive heart failure, angina, diabetes, dyslipidemia, AFib, and nicotine dependence. He has no allergies to medications, latex, or food. He smokes a pack of cigarettes a day. He denies alcohol intake, and he stated his father died at 75 from COPD complications, and his mother died at 78 from breast cancer. He has no other brother or sisters. He takes Eliquis, aspirin, atorvastatin, Plavix, Lasix, Imdur, lisinopril, metoprolol, and Renexa. However, he stated he has not taken any of his blood thinners because he felt he was becoming more bruised on his arms and legs. Vital signs were 92/46. His heart rate was 89. SAT was only 91% on 4 liters nasal cannula. He had an elevated white blood cell count of 18. BUN was 22, creatinine 1.8. D-dimer was elevated at 2.25. Blood gas showed a pH of 7.34, PCO2 of 50, low PO2 of 50, and a bicarb of 24. His assessment showed an elderly, well-nourished male who was in slight respiratory distress. His neck was supple. He had no JVD at the time. Lungs were very diminished equally. He had a regular rate and rhythm. No murmurs were detected. He was diaphoretic and cool, and he had +1 edema noted to his bilateral lower extremities. Portable chest x-ray showed atelectasis with COPD changes. CT of the chest with PE protocol showed a large saddle embolus. EKG was AFib with a rate of 99. Echocardiogram showed ejection fraction of 40%, and he did have right ventricular strain and dilatation. This can be found with patients who have large saddle emboli. Differential diagnoses include pulmonary embolism, COPD exacerbation, myocardial infarction, and congestive heart failure. Pulmonary emboli can form when the clot breaks off from the vein wall. This usually originates from the lower extremities. It can occur because of smoking, irregular heart rhythm, and advancing age. Unfortunately, this patient had all 3 things. He smokes every day, a pack of cigarettes, he has AFib, and his age is in the mid-70s. He needs anticoagulation immediately, and it needs to be continued post-discharge. So medication compliance, especially with his blood thinners, it's going to need to be stressed to this patient when he is discharged. Treatment plan will include admission to the ICU. Supportive care will be given, anticoagulation. He became unstable. His blood pressure became very low. He was very short of breath, so it was decided to take him to the cath lab for the EKOS catheter placement, and because he had the right ventricular strain. And what they do down there is they do a right heart cath. They usually use a 5 French pigtail, and they inject contrast to see where the emboli are, and they try to find the largest one and direct the catheter towards that to infuse the TPA. We're going to monitor frequent lab work, medication compliance education will be given, and smoking cessation counseling. Fibrinolytic therapy has shown to decrease the morbidity and mortality associated with PE. The right heart cath was performed with the EKOS catheter placement. Alteplase was infused at 0.5 to 2 milligrams an hour for a total dose of 20 milligrams. During this time, he was given half dose heparin IV therapy. Goal was kept at 40 to 60 seconds for his PTT. Once the alteplase was stopped, he was given full dose heparin IV. Goal of PTT was 60 to 80. transition him to oral anticoagulation therapy, monitor for signs and symptoms of bleeding, and limit venipuncture and IM injections during the ultraplace infusion. His hospital course was good. He became hemodynamically stable after 6 hours into the infusion. Repeat echocardiogram 24 hours later showed improved right ventricular function. His sheaths were removed 8 hours after his infusion was completed. On day 4, he was transferred to the step-down unit and a couple days later was discharged home. Instructions on PE and importance of being compliant with his Eliquis and other medications was given. He was also given smoking cessation counseling and resources.